Good day, everyone. We are the Group 2 and we are here to discuss on an interdisciplinary approach for management of periodontally compromised orthodontically treated patients. Periodontal disease is generally the result of infections and inflammation of the gingiva and the bone that surrounds and support the teeth. In addition to that, it is the destruction of the periodontal ligament. Bone loss will occur, and if left untreated for a long period of time, teeth will become mobile and eventually tooth loss will be the end result. Before any kind of dental treatment, the health of the oral health has to be the main priority. That is the oral cavity that plays a crucial role in ensuring the long-term prognosis of various dental treatments like orthodontics, prosthodontics, and etc. The geographic variation in periodontal disease prevalence have been discovered, and they were mostly related to differences in socioeconomic situations, behavioral factors, people's systemic conditions, and dental hygiene patterns. Periodontal disease affects different populations at varying rates of prevalence and severity. Periodontal disease is more common as people age, according to research. Additionally, a variety of exposure profiles including diabetes mellitus, smoking status, educational attainment or socioeconomic position, access to healthcare, and oral hygiene practices needs to be taken into account for a better understanding of the factors influencing prevalence variance. For our case report, a 28-year-old patient came to our clinic complaining of swollen gums completing her orthodontic treatment in a private setup. On clinical examination, patient presented with abundant calculus with an oral hygiene index of 3.3, which refers to a poor oral hygiene status. The patient presented with a generalized erythematous gingiva with diffuse gingival enlargement, a generalized deep true pocket with average probing depth of 7 to 8 mm with grade 2 to grade 3 mobile teeth in 1-1 and 2-1 respectively. So for our treatment plan, with the diagnosis of the patient, the treatment plan requires a collaborative approach in treating the condition of the patient. Collaboration of numerous dental specialists such as an oral surgeon, periodontist, orthodontist, and a prosthodontist are needed for the treatment plan to be carried out successfully. The proposed treatment plan included an initial non-surgical therapy, full mouth flap surgery with platelet-rich fibrin, hydroxyapatite bone graft, and subsequent aesthetic rehabilitation along with re-evaluation in between the treatment phase. The patient was explained about the treatment plan and informed consent was obtained.
A collaboration between periodontists and orthodontists should be needed before any orthodontic treatment. With this case, it is possible that the patient underwent a complete orthodontic treatment without thorough periodontal examination, which resulted to a severe periodontal disease. During the execution of the treatment plan, there is a collaboration between the periodontist and prosthodontist, which was evident after the surgical intervention or bone grafting that included internal bevel gingivectomy and modified Widman flap surgery. After the periodontal surgery, a gingival prosthesis was fabricated by a prosthodontist as an alternate treatment option to solve the unsightly black triangle in the anterior aesthetic region caused by the loss of interdental papilla. With this, their collaborative efforts allowed them to rehabilitate the aesthetic and functional needs of the patient while attending to the requests of the patient to avoid another traumatic and extensive surgery and yet another orthodontic treatment.
This study will be composed of a multidisciplinary team of an oral surgeon, periodontist, orthodontist, and a prosthodontist to further assess the condition and provide the appropriate and necessary treatment plan for the patient. After the patient was diagnosed with generalized chronic periodontitis with inflammatory gingival enlargement, the patient was informed and consent was obtained to go through the treatment. So the first part of the treatment is the phase 1 therapy, which involves patient motivation through scaling and group planning. And then, maintenance phase. Recall once a month to assess the response of phase 1 surgery, and re-evaluation for clinical parameters such as gingival inflammation, probing pocket depth, gingival enlargement, mobility was done after a 3-month period. An extracoronal wire and composite splint on tooth region 1-3 to 2-3 before regenerative surgical procedures to manage mobility with 1-1 to 2-1. Upon the improvement in the patient's gingival health, surgical intervention was performed that included internal bevel gingivectomy and modified Widman flap surgery to manage the gingival enlargement as well as persistent pockets. Regenerative procedures were done on angular defects detected in 1-1 and 2-1, whereas in 1-6 and 2-6, both showed 3 wall defects with grade 2 furcation involvement seen in 2-6. After complete debridement, root biomodification was done with tetracycline. PRF was prepared by drawing 10 ml of patient's whole venous blood from antecubital fossa into sterile vacutainer tubes without anticoagulants. These tubes were then placed in a centrifugal machine at 3000 rpm for 10 minutes. A fibrin clot is then obtained in the middle of the tube, just between the red corpuscles at the middle and the acellular plasma at the top. The PRF was compressed on a glass slab to form a membrane and placed in the furcation defect of 2-6. Flap sutured and periodontal dressing was placed. On image A, it shows a regenerative surgical procedure done with platelet-rich fibrin and hydroxyapatite bone graft in the vertical defect of 1-1 to 2-1. On image B, it shows a regenerative surgical procedure done in the tooth region of 1-6 and 2-6 using platelet-rich fibrin and bone graft. After the surgical intervention and regenerative procedures, post-operative instructions was given. Refrain from mechanical plaque control measures in the surgically treated quadrant for 2 weeks and no intrasulcular brushing for 8 weeks. Soft diet is also advised. The patient was advised to use chlorhexidine 0.2% rinse until the completion of the treatment. Amoxicillin 500 mg thrice daily for 5 days, ibuprofen twice a day for 3 days, and then sutures were removed 7 days post-surgery. Patient was scheduled for maintenance therapy, recalled every 3 months in the first year, and then recalled every 6 months for 2 years. On image A, it shows post-operative photograph showing periodontal stability. Image B shows pre- and post-operative intraoral periapical view of 1-1 and 2-1 region showing bone fill. On image C, it shows the post-operative orthopantomography. Now, this is what the gingiva looks like after the extensive therapy.
Recently, there has been a surge of interest in the association between periodontal disorders and the long-term prognosis of various different treatment options used by other dental disciplines. This integrated approach between specialization is the key to success, resulting in improvements in function, aesthetics, and quality of life. The long-term success of the treatment strategy is contingent on expert execution. Phase 1 therapy was used to achieve the first goal of periodontal stability. Surgical intervention then managed the gingival enlargement together with regenerative procedures afterwards. With their collaborative efforts and help of a prosthodontist, the patient was satisfied with the aesthetic achieved after a valve plus gingival prosthesis was fabricated and used. Overall, the comprehensive treatment procedure done were able to meet the aesthetic desires of the patient as well as the functional rehabilitation.
Discussion. long-term prognosis is dependent on the professional execution of the treatment. Achieving periodontal stability should be the first priority before proceeding to different dental treatments. As observed, advanced bone loss with deep angular defects together with increased mobility was seen in the maxillary anterior teeth of tooth 1-3 to tooth 2-3. A conventional splint therapy was indicated to help in distributing the applied forces to and help increase resistance. This makes sure that the forces do not exceed the remaining adaptive capacity of the periodontium. This restores functional occlusion, increases the masticatory function, and also stabilizes the mobile teeth during regenerative surgical therapy. The primary objective of this case is to undergo periodontal therapy by gaining access to the deceased root surfaces and restore the lost periodontal tissues. The goal is to ensure that the lost periodontal tissue will regenerate and provide adequate stability. This will include the formation of the alveolar bone, cementum, and periodontal ligament along with the gingival tissue for adequate sealing. In this case, the use of PRF or platelet-rich fibrin or HA or hydroxyapatite crystals were needed in the regenerative surgery where deep intrabony angular defects were seen. PRF is a second-generation platelet concentrate which is considered as a autologous healing biomaterial. These will help stimulate periodontal regeneration. HA is an artificial substitute for bone since it is biocompatible and will not cause an allergic response. After regenerative therapy, mobility was improved and radiographic evaluation was done after 6 months, which showed bone fill. The patient was then followed up for 2 years and complete stability of the periodontium was achieved. Due to this periodontal surgery, the patient had developed an unsightly black triangle. This black triangle was due to the loss of alveolar bone. The patient insisted to not go for another extensive traumatic surgery and to also put into consideration the age and patient's aesthetics demand. An alternative treatment was given. A gingival prosthesis was made with the use of a Valplast material which is highly biocompatible. Patient needs to maintain proper oral hygiene and maintain the cleanliness of the prosthesis as well. In conclusion, correct and complete diagnosis, comprehensive treatment planning, and the application of interdisciplinary interaction between orthodontist and periodontist are the hallmark of the success of this case. Such complex cases are multifactorial in nature, which needs the assistance of specialists, which could help in creating the most optimal treatment plan for the patient. This case report has not only dealt with the periodontal stabilization with the use of PRF and HA, but also highlighted the alternative non-invasive prosthetic rehabilitation for the loss of the interdental soft tissue. The patient desire of aesthetics was met by the use of the Valplast gingival prosthesis. This shows that the interdisciplinary approach between specialists is the key to long-term and successful treatment for the patient. Thank you. These are my group members: Cabigas Ninya Bridget, Kailipan Drew, Purot Ariana Beatriz, and Pablero Joshua Junil.